Welcome to Talking with Tech. My name is Chris Bouguet, and I'm here with Rachel Madel. Rachel, tell us all about the listener question we got this week.
We did get a very interesting listener question, and I'm excited to kind of dive into this because, you know, we get a lot of questions, and I feel like sometimes I'm like, oh yeah, we've got this question. We've never got this question before. So I'm excited to talk through it with you. Okay, so the question says, some SLPs in our school district have been coming across some interesting cases that incorporate complex communicators, ASL, American Sign Language, and AAC. We would love to get your input. These are students in our life skills classroom who are non-speaking or minimally speaking. They are not deaf or hard of hearing, but have been taught sign language by their families or other students' interpreters at school. And they use this as their primary mode of communication. These students have also been provided with AAC devices, but demonstrate that ASL is their preferred language modality of communication, and they are demonstrating language growth in sign. Their families have expressed a preference for using sign at home. Our district is declining to support sign, example, interpreters, for students who are not deaf or hard of hearing, and is advocating for AAC as an alternative to sign. As an AAC team, we feel that replacing a student's preferred mode of communication with AAC is not a productive or ethical use of AAC. AAC might be an appropriate support, but not a replacement. We're concerned about an attitude that is developing among our administration of, quote, just give them AAC, end quote, for any student who doesn't have full access to verbal communication, even when the student is developing another language as well. We often train staff to model AAC like it is another language, which is appropriate in most situations. However, we are finding this topic more complicated when ASL is incorporated. ASL is obviously another language, and AAC is not a substitute for that. Therefore, we are having trouble explaining this to our admin, that AAC is not a problem solver for those that prefer to communicate through ASL. We would like to be able to present information to our administrators on this topic, but we're having difficulty finding any research in this area. We were hoping you might be able to point us in the direction of any research you might know of or any experience you might have with this issue. What do you think, Chris? Let's dive in.
All right. Well, it starts with asking a lot more questions, because it's hard in an email. We make a lot of assumptions based on this. So I'll start with a handful of questions, and maybe we can riff on that. How does that sound like
Sounds great.
All right. With my experience with ASL and people who use ASL as a form of communication when they're not deaf or hard of hearing, is that it's often some sort of version of ASL, meaning it's not often precise, and it's just a number of words. And I don't know, it's often highly customized, if that makes sense. So that's my first question here, is when they're using that, and it's said that it's their primary mode of communication. Does that mean they're using it that they can already say whatever they want to say, however they want to say it, to whomever they want to say it? Right there, I'm going to imagine no, because a lot of people wouldn't be able to recognize, even if it was accurate sign, right? So it can't be, the answer to that question would be, it can't be everyone, right? But what does that look like? Like, how many words do they have? If we were doing a language sample, we would say do a language sample for a kid using AAC, do a language sample for a kid who's learning sign. What does that language sample look like? So that's my first question.
I love those questions, Chris. I also, this is really unique for me because I actually haven't experienced a lot of students who I would consider complex communicators, who are choosing ASL as their primary form of communication. Because, as you mentioned, I oftentimes am working with students who do use multimodal communication, and they're using gestures, and they're using signs, and they're using some verbal approximations, and they're using AAC, and that is very common. Most of the time, what I'm seeing with sign language is that it is very much approximations of signs or home signs. There's lots of different kind of labels that we might use, but they're not, as you mentioned, as precise. I oftentimes also see students who have learned signs as kind of an initial form of communication, and they've learned the sign for more. They've learned the sign for drink. They've learned the sign for eat. They've learned the sign for all done. But then when it comes to kind of utilizing those signs, they will overgeneralize and not use those signs with specificity. It's kind of like they're going through a Rolodex of like, these are the signs that I learned that got a really great outcome at one point. So oftentimes I'm seeing that students aren't using signs with accuracy and aren't able to be as intentional with using signs in situations. So this is unique in that situation because it sounds like these students really are acquiring sign language. And I also think it's worth mentioning students will learn whatever you teach them. And so it sounds like they have interpreters because in this question it said sign language is being taught and other students' interpreters are teaching signs. So of course, like our students will learn whatever we teach them. And so I think that's a really good reminder is that whatever we introduce to a student, they will learn. It also sounds like AAC has been modeled for these students. But I guess the question I have is what's being modeled more? Because I feel like what's being modeled more likely will indicate what students are going to be using more. And so I have that question because I'm wondering, it sounds like there's a lot of really great sign language being modeled. Again, these are all like assumptions based on this very, short email in the grand scheme of things that we got. But I'd be curious the order in which these modalities of communication were modeled, the frequency at which they were modeled, because I think that can give us indications as to what students are more likely to be utilizing.
All right. I have some assumptions because I have seen this a handful of times, not to the extent that I think they're referencing. If I had to guess, I think they're probably talking about students in upper middle school to high school, probably high school, because they have expressed this is my preference, right? Where maybe in kindergarten, they're not expressing what their preference is yet, or we have more of an open mind about, they might have an open mind and parents might have an open mind because now about what to use. Like, oh, okay, let's talk about, when I say open mind, like I can consider different options, right? Where now at high school level, I've been using this option for years and years and years. So I think of myself, part of my identity is someone who uses ASL or a version of it. And my family members have got used to understanding what I mean using my customized signs or true American Sign Language. So my thought here is that these are probably high school students. And one of the barriers is if you were to implement AAC in a voice output device right now, you'd have to convince them that that's going to be less effort than what they're currently doing, right? So, and that's years of being reinforced and taught. So when you say they've probably been modeled to AAC, my guess is, just in that it's 2024 and how long AAC has been around, my guess is that they've probably used picture symbols when they were in kindergarten, first grade, something like that. Then maybe we started using some voice output devices for some of these kids, but others not. And then when we get to high school, we've spent so many years just reinforcing the modified signs that I'm comfortable with it. Why would I need to change? That'd be my guess.
Yes, I think that makes a lot of sense. I was also anticipating these were older students. And I think I'm anticipating that too. I've worked with many students who I have introduced AAC to later on. I worked with a 23-year-old who had never been introduced to AAC. And that student had a ton of signs. And that was because they didn't have anything else. They were never introduced to AAC. It sounds like that's not the case in this situation. The students are being introduced to AAC, but our students are comfortable with the communication that they've been using the longest. And so to introduce something new, probably there's a learning curve for that, meaning like, what is this new thing? Like, I can get my needs met perfectly fine with using what I do, which is signs. I also think part of this question is their families have expressed a preference for using sign at home. So obviously, my thought is we're there to support families. The question mark is, one of the big challenges I have with sign language is that it's not universally understood. It's a language that you have to learn. And so I always want to try to help support my students in a way where they can go into the community, they can go to Starbucks, and they can order a drink that they want independently and have a barista understand what they're communicating. And so I guess the question becomes, how do we help supporteds in that endeavor? Because ultimately, especially if we're talking, about students who are potentially transitioning out of school, how do we prepare them for a future where they have to, interact in the community and they are able to be successful in those interactions? And even if a student's primary mode of communication and preference for language was ASL, there are opportunities to introduce scenarios and situations where someone doesn't understand my language. And so I think there's still an opportunity here for AAC to showcase those breakdowns. And I think it's really a responsibility to share with parents some of the limitations of ASL. And maybe this has already been done, but this is my clinical thought process as to, what kinds of things do I need to make sure that I'm teaching?
That leads me to some questions that they might ask the family. So it says here, their families have expressed a preference for using sign at home. I feel like there should be a clause after that says, for now. Because the question I want to ask the parents, like you were using the Starbucks example. Okay, parents, tell us what you think the future looks like. What job do you hope they have? Will the people that they work with in that job understand sign language? Do you expect to be with them when they're doing that job? They might already be thinking, oh, and this might be true, I don't know. But it has been, again, I have a little experience of families like this. They're never going to get a job. They're going to be with me for the whole life. But what if we said they could? Okay. Let's presume that they could, that they would. And what if we work towards that as the reality of what we want to happen rather than they're going to be with you? Let's give them that option, right? And then the second thing is, let's say you're not here. Let's say you're not here anymore. How do they defend themselves? How do they report back that something is happening to them? So they can report it to you through sign, but what if you're not there? What happens if something happens to you? Do we want to prepare them for those skills? So AAC is an option. What is the ultimate option, though, is literacy. If we can teach them to spell, then if we can teach them to write and teach them to spell, close enough that they can use word prediction, then they can use those in a job. They can use ASL, they can teach people ASL, and they can also type things in and show people like the text that they wrote, the notebook that they write it in, however they want to do it, of an AAC app that you type it out and you hit a play button and it reads what you typed out without symbols, right? That might be more palatable to people going, right, of course we're going to teach them how to read and write. Great. Then we have AAC in a different format that's not symbolized communication.
Yes, I love that you mentioned that literacy piece, Chris, because again, when we're thinking about our students as they transition out of school, we start thinking like, what's going to make their life easier? How are they going to stay connected in the community and navigate their life as independently as possible? In this question, it says that we're talking about students in a life skills classroom. That leads me to believe that these students don't necessarily have full language, meaning like they have a lot of language learning to do. Because my biggest question here is the one you started with, which is, let's do a language sample. How are they communicating? What words are they using? Are they using grammar? Are they what level are we at here when it comes to their language? Because that really is what it boils down to for me. Is ASL limiting their potential for language learning? And how are they universally understood in the community? And I think those are the two big questions here. So, I think when it comes to, AAC and feeling like it's replacing a student's preferred mode of communication, I don't think so, because I think that we can adopt multi-modality communication strategies and help support all the different ways that students are communicating. But at the end of the day, in addition to supporting multi-modality communication, we also have to teach students when there's communication breakdowns. So I would be really focused on using sign language and using sign language with someone who doesn't know ASL, because that's the reality that these students will face in the community, is that I will go to sign something to someone and they won't understand. So do the students understand I now have a backup means of communication with my AAC device? So I think that, no matter what kind of course or path we take, AAC should be included because it's the one thing that's universally understood. And I think that there's so many opportunities here to teach about communication breakdowns. And it's totally fine if a student wants to use sign language as a primary mode of communication. But how do we teach students to expand, to repair communication breakdowns, literacy with typing, word prediction? Like, there's so many tools at our disposal in 2024 that we can utilize to really create robust opportunities for language and language learning and overall communication for students.
Mm-hmm. I think some real practical strategies that they could put in place, especially since they put that administration is in just give them AAC. Like, what? Like, that's
We're never
awesome.
in this situation, Chris. We're like, wow, the administrators are saying just give them AAC. Like, what a win.
Exactly. They'll put dollars behind that, right? So a way you could do that practically is say, all right, administrators, give me, the educator, the AAC. I'm going to be in the classroom with them when they do ASL. I'm going to say, here's how you might say it. Here's how you might type it in. No pressure on you, dude, to do anything. Dude being the person who uses AAC. I'll just do it and I'll model it. And then eventually here's an option for you, so that we're not forcing it on anybody or making anybody feel uncomfortable. It could just start with it being in the environment. And then it's an option for them when they do have the experience where they're not understood. Oh, well, see, it's right here. You could use mine if you want, which then could cascade to getting your own,
Yeah, I think that makes perfect sense. I think the other thing that's interesting here is that, traditionally, those who learn American Sign Language are in the deaf and hard of hearing community. And I think that is not only a language, but it truly is a community. And my question would also be, how do these students fit into that community? Because if they're going to go all in with American Sign Language, and that's the kind of primary mode of communication, the other question that comes to my mind is, how are they integrating with the deaf and hard of hearing population and community? How many opportunities do they have to engage with that community? Because ultimately, we want our students to be around other individuals who speak their language. And so that would be another question that comes to mind, is like, how many opportunities have there been to engage with, individuals that have full language using American Sign Language? They have the ability to say whatever they want to say to whoever they want to say it to. And so that would be another question that came to my mind, because again, if we're thinking long-term for these students, if they're using American Sign Language as their primary mode of communication, we would want them to be integrating into that community.
Yeah. Nobody will fight teaching literacy, right? And that will work in any of the communities as long as someone's literate. So, and what if someone's not literate? Then, hey, what if we had a play button so they could hear, so I have all these different modalities for you can read it and you can listen to it if that works for you. It seems like the answer here, it's not an either or, it's a both, and you got to teach literacy.
Yes. I love it, Chris. This was such a good question. Thank you to the person who reached out and shared this. This was a really good thought experiment for me to kind of go down like, what do I think about this? How would I approach this situation? And I think it's a really good question. And I can understand some of the challenges here, especially with the need for interpreters and there being a cost associated with that. I totally get that. My last kind of idea would be, how could we potentially support the interpreters in multimodality modeling, right? Wouldn't it be cool if the interpreters here learned how to interpret using sign language and also model using AAC? Like, what an inclusive way to integrate potentially. So I think, at the end of the day, multimodality communication is something that almost all of our students are utilizing, right? And so we need to kind of support that. And sometimes we need to get creative on what that looks like. And I think sometimes we kind of have tunnel vision on like what we think is the best form of communication. And, I think that having really rich conversations with teams, with families, with students themselves helps kind of open up our perspective and think through the lens of all the different ways that students can communicate and supporting those ways. And of course, modeling language in all the different ways that students can communicate.
Now, a great way to teach those interpreters is to invite them to join our Patreon, Rachel. And we have some new Patreon supporters, don't we?
We sure do, Chris. Alyssa and Dr. Margaret have joined our Patreon. We want to say a special thank you to all of our members who have joined Patreon. It truly is the reason this podcast exists. We have a team of people, Luke and Michaela, behind us. It's not just the Chris and Rachel show. We are a team and we need support. And we appreciate your support. So if you love this podcast and you want to support us, you can go to patreon.com/talkingwithtech. We have 5 years. Is it 5 years of content, Chris? How many years have we been doing Patreon? It's been a while.
A lot. Yeah.
You have endless amounts of content, besides behind the scenes, interviews, questions, Q&As, tons of resources, therapy ideas. There's so many things in the Patreon and we keep adding to it. And we just want to say thank you for everyone who supports us via Patreon. It truly is so meaningful and we are so grateful for that support.
The last thing we have to say before launching into the interview is to tell you about our upcoming recast episodes. So the way the summer is going to work is there'll be a week off after this episode, and then we are going to play 4 classic episodes. Most of those episodes are going to be exactly how they were, just think of them as remastered, right? We are going to do a little banter for one of them, which was surprise. We'll wait.
Foreshadowing. It's a really uncomfortable conversation for me, so don't miss it.
And then after those those recast episodes, there'll be another week off, and then we come back for the next school year, right, and launch back into a whole bunch of episodes. In fact, we already have some great ones coming up that are scheduled to come after the summer break. So we hope you enjoy these classic recast episodes. And then let me tell you about the interview today. So the interview today is with someone named Caroline Woeber, and Caroline works in a hospital setting, which has been a focus for Rachel and I through the last. We made this sort of a public goal. I don't know, maybe is a bunch of episodes ago. It doesn't matter. We just have decided a long time ago that we need to focus on other settings than just schools. And so we said we needed more hospitals. And so Caroline Woeber is one of those people that we've had this conversation with. And bonus, Caroline also works for a summer camp, an AAC summer camp, or works with an AAC summer camp, and she's going to talk all about her experiences there as well. So without further ado, let's listen to my interview with Caroline Woeber. If you enjoy Talking with Tech, we could use your help in spreading the word about the podcast. Please take a moment to leave us a review on iTunes. The more positive reviews the podcast gets, the easier it becomes for others to find it. The more people who find the podcast, the more the word spreads about how to effectively consider and implement AAC. And who doesn't want that? If that sounds good to you, please take a moment and give the podcast a quick review. We'd so very much appreciate it. Now, let's get back into the episode. Welcome to Talking with Tech. My name's Chris Bouguet, and I'm here with Caroline. Caroline, we met at ATIA, and I don't know that I remember your last name, how to pronounce it. So let's just jump in. Caroline, tell us your last name, please, and and who you are and what you do.
Hi, I'm Caroline Woeber. I am a speech therapist, and I specialize in AAC at Children's Hospital Colorado. And I've been a therapist since 2013 and in my role at Children's since 2016.
Awesome. So Caroline, like I said, we met at ATIA. You stopped me in the, passing and said, "Hey, you're Chris, right? From Talking with Tech." I am. And then we got chatting a little bit. And you said how you work at a hospital setting, right?
Mhm. Yep.
And I said, that's amazing because Rachel and I have been talking about how we need to reach out to other settings that are working, where people are working with AAC, and not just private practice, not just public schools where I work, right? But other settings, and have them on the podcast. So then you and I chat a little bit about some of the stuff you do. And if I remember correctly, too, you do a little work with camps, too, like AAC camps, right?
Yeah. In a lot of ways, I feel like I do a ton of different things, and I feel so grateful for the variability.
Awesome. Well, let's get into all of them. Okay, so let's start with how did you become a speech language pathologist, and then how did you get interested in AAC?
Great. I graduated with my undergraduate degree from the University of Florida with a degree in Spanish, which, as a non-native speaker, I knew I would have a lot of work to do in that area to continue to develop that skill. So just weeks before graduation, I really owe it to my mom, who put the seed in my head of, have you ever thought about speech therapy? And lo and behold, I started talking to more and more people. And my best friend's mom is a speech therapist. Dr. Janet Whiteside is an ASHA fellow and now retired from the field, but is my mentor and has just continued to introduce me to the field and support me throughout my career. But then in graduate school, I attended the University of Central Florida, and my first clinical experience was in a middle school where many of the individuals had AAC tools and strategies, and I loved it. There's a part of me that just loves the technology, and then getting the chance to open up communication and dialogues, conversation. It just was so amazing. Not to mention then working on a team with teachers and paraprofessionals. I really loved that kind of multifaceted dynamic.
Awesome.
Field.
Let me just dig into that for a second. So when you're there and you're learning about AAC, and you said this is like 2018-ish?
Oh, so no, I got my degree I graduated 2012. So I would say my first clinical was about 2010.
Oh, okay, 2010. All right, so the technology there, like 2010, that's when like iPads were just coming out, right?
Just coming out. I mean, I remember programming, what was it? The Dynavox Maestro, big old brick. Yeah.
Awesome. Okay, and then what happened from there?
Yeah, so I knew I wanted to be an AAC. I got my clinical fellowship in the public school system, and then I went on to some private practices, but never quite got the robust mentorship that I think is really helpful and needed for the area of AAC. So in 2016, I got a job at Children's Hospital, and I feel incredibly indebted and grateful for my clinical practice specialist, Lisa Martin, who has just been a mentor and a champion for me in developing my AAC skills. And now I'm evaluating and treating AAC more than 90% of my caseload. I'm running 2 AAC camps, and I just love the kids and families I work with.
Awesome. So that's not in Florida, that's in Colorado, right? You moved from Florida to Colorado?
Yeah, so I made the move in 2015 from Florida to Colorado and never looked back. I love the weather and the change in season. I'm surprised myself by that.
That's awesome. All right, so tell us a little bit about the work you do so it's a clinic? You call it a hospital, a clinic? What's the words?
Right. Excellent question. So I work for Children's Hospital, Colorado. We have inpatient therapists. We have a team of like 25 speech therapists that focus solely on AAC or have a mixed schedule of AAC. And we have inpatient therapists. We have clinicians that are working on multidisciplinary teams. And then we also have outpatient therapists. So I work in a few of those realms. I have an outpatient clinic that I go to where it's more of that weekly 1-hour therapy sessions, supporting kids in learning to use devices, ongoing therapy for language using a device, as well as evaluations and other just things that come up, right? And then there's the multidisciplinary clinic, which I think is what we were talking about a little bit at ATIA this year. And my specific clinic that I work in is the Chromosome 15 and related disorders clinic. However, the hospital has a whole host of different multidisciplinary clinics that work with individuals with DeGeorge syndrome or with Down syndrome. The C Center for Down syndrome is world renowned, as well as like VPI clinic and things like that.
So Chromosome 15, can you talk a little bit about working in that clinic and what that's like?
Absolutely. It's so much fun. We have like almost 8 providers that families get to circle around with. So the idea is that families come to the clinic for one day, about 4 hours long of an appointment, and get to meet with all of the professionals on the team. So we have an epileptologist, a pediatric rehabilitation physician, genetics counselor, dietitian, occupational therapy, physical therapy, and speech. And we all work very closely to come up with a really great treatment plan for the families and give them guidance on specifically the disorders that are related to our clinic, which are Angelman syndrome, duplication 15q, as well as Angelman-like disorders that includes Pitt-Hopkins, SYNGAP, and CHD2.
Okay, let me break that down for a second. So
That's a lot.
Does a family, how do they get to know about you in the first place? So that they, when you say they come there and they meet with all of the different professionals, what's the step before that for a family?
So families are often connected. They will receive a diagnosis that their child has Angelman syndrome or duplication 15q. And often one of the first places that families will go is to the foundation's website. So for Angelman syndrome, that's the Angelman Syndrome Foundation. And then there's also duplication 15q. Theirs is called the Dupe 15 Alliance. And they'll go to these websites and they'll see that there's clinics around the world. And they'll choose which one is closest to them or has the kind of providers that they're hoping to receive. Some locations are considered centers of excellence. So ours at Children's Hospital of Colorado is considered a center of excellence, whereas other ones, there may just be 1 or 2 providers that are there to help support the family.
Okay, so then people look on the website, they see a clinic that maybe is in their geographic area. Is that is there enough that, or do people have to do some major traveling usually to get to your clinic?
Yeah, we've had families who, in general, because of Children's Hospital Colorado being a pediatric hospital that serves the 7-state region, it's not uncommon for us to serve families from Montana, Wyoming, New Mexico. But in addition to that, yes, we've had families travel from around the world to come to our clinic.
Amazing. Amazing. Okay, so they get there, they come in, and then you said they meet with a series of professionals. Is it like you come in a room and one person comes after another, or is it like you're sitting at a table and everyone's there and you're all talking all at once? How does it work? What's this? Yeah, let's start with that.
The majority of situations are, it will be 1 to 2 providers will go into the same room that the family is in and meet with them. So the family doesn't have to schedule a bunch of appointments on separate days or even go from office to office to office. We come to the family and answer all of their questions or give them ideas.
Gotcha. And that's like a typically a day-long thing?
So we have, it typically is about 4 hours.
Okay. And somewhere in there, I'm going to guess that for some students, you're thinking about AAC. And in fact, maybe I'm going to just guess most students, you're thinking about AAC in some form or another. Is that fair?
Absolutely. So there is still a wide range of abilities that we come across of. And even though we have some kids who may rely predominantly on their AAC tools and strategies, we do have some individuals that still benefit from assistive tech to support their natural speech and things like that.
Okay.
But yes, so majority.
Yeah, I would imagine. So what does the assessment process look like? Like like I know what it looks like well, at least in my neck of the woods of school. I think there's some variations in schools and all over the place. And I think that's evolving. But what does it look like in the hospital setting at your clinic?
Absolutely. So I really try and take my role to be as thoughtful as possible. I don't want to be a therapist evaluating a family who's come from another community and cloud the situation or make the situation more complicated. So in addition to that, I recognize these families are meeting with 7, 8 other providers and are absorbing a ton of information. So I really take my role as evaluating what is the priority for the family in that moment and how to make my recommendations really meaningful so that the family can just take it home and use right away.
Take it home and use right away. So will people leave that day with something?
Yeah, so I try and give families really tangible things to take home with them. Many of our families already come with a device from their current home community. And so it's really thinking about how we tweak that. If they don't yet already have a device, that would absolutely be one of my recommendations to go and seek out an evaluation for that.
Gotcha. Okay. I was sort of under the impression this is why we need to do podcasts like this, because in my head, I was sort of thinking that you were doing the evaluation, but really kids are coming, families are coming. Clearly, there might be in a public school setting, right? And then maybe someone in that school setting has done something and has suggested something, and maybe they're implementing something and they're coming to you to either, like maybe the next step on the journey. And you then say, hey, oh my gosh, this is good. Or, here's some things to think about. Or, oh, you don't have anything at all. Let's go find someone that can help you do a more robust consideration of your needs. Is that all fair?
That is, yes, absolutely it. I would say it's been so interesting. I've been in the clinic since April 2020. I've met so many wonderful families and clinicians and gotten to collaborate in such meaningful ways. It's also still surprising to me how many times the same myths and misconceptions are still pervasive in our community, right?
Mm-hmm. Like what? Can you think? I'm like if I use AAC, they won't talk, stuff like that.
And maybe not as much within like the Angelman community, just because that is often the best evidence-based practice to get a child to have access to the device or an AAC device. I think it's more of, I'm always so surprised when a family says, oh yeah, we never send the device to school. Or the school won't send the device home. And it's amazing to me that still happens, or that they'll have one device at school and one device at home, and they're totally different systems. And it's amazing how these kids still get their message across too.
Right. Okay, so those things continue to happen. But would you say in your time there, have you seen that decrease, be stagnant, or increase?
I mean, I guess stagnant. And I don't know if that's because I always have new families coming that share these stories. And I want to validate that there are still some times that this happens.
Yeah, well, that's exactly why we have this podcast, right? Is to start to change those sorts of mentalities, bust those myths. And that's why we do these interviews so that maybe a family down the line will hear this and go, oh, that's a myth. Okay, so, we can bring the device home. Oh, we should have the same system maybe so that there's some synchronicity there between environments. Like, okay, great. So is it fair to say then that is it a one and done? Like they come in and they meet with you and they get some advice and then they leave, or is it an ongoing relationship?
I think that's what I love about it, is that in most situations, it is an ongoing relationship. Of course, for our families who are coming from pretty far, it's going to be hard for them to make an annual trek to the clinic. But for many of our families, I get to see them every 6 months to a year and get to check in and see, okay, what are we doing now? What can we add? What can we change? How are you feeling supported with your strategies?
Okay. So is it usually like 6 months to a year?
Mm-hmm.
Okay. So you're checking in with them just once or twice a year. Okay. That makes sense. It makes sense to me that how you're describing it. And so that would be following up to make sure that things are being implemented in some way, right? And then find out what kind of supports they need and give them some other advice. That's generally what happens.
Yeah, I would say so. With some families, it feels a little bit like an accountability check of, okay, I'm going to write this down. And in 6 months, I want to hear about how we're progressing in this area. And then for other families, it's more of we want to celebrate this. Let's celebrate this together. And I really love that opportunity to do that.
That makes total sense to me because a phenomenon that I think often happens, Caroline, is that any person who's with another person, like day in and day out, that incremental growth is hard to measure and it's hard to see. And sometimes it's hard to celebrate because you don't even necessarily see the progress that's happening. But then they come to you and you're like, I remember you from 6 months ago or a year ago. And now, you've grown bigger, your language has grown, hopefully, right? You as a person has changed, and you can reflect on it, and then, like you said, celebrate it with the families to be like, oh my gosh, look how far you've come, right? That sort of thing.
100%. It is celebrating when we get those devices and we see that robust language. It's like, yes, we're making steps. We're doing the right things.
Oh, that's awesome. That's awesome. So, okay. So have you seen some like effective AAC technologies that have sort of worked, and along those lines, because it doesn't have to be a specific device necessarily, but maybe
Right.
specific ways that the AAC is set up, or techniques for implementation that have been helpful, or any kind of customizations that sort of permeate across your experience.
Absolutely. So I think always having the people programmed into a child's device or individual's device is so meaningful. So anytime that we can make those personalizations, I think really help all individuals with the device, but particularly the individuals that I see in the clinic. I would also say that so much of what I do is really tailoring it to support the individual and family. And I really want to be thoughtful and, like, as you mentioned, avoid saying like this tool is the right one.
Mm-hmm.
Specifically for Angelman, there is a component where individuals will have a tremor. So often, if that child is or individual is presenting with a tremor, that we're being really thoughtful of what kind of key guard or supports do they need. At the same time, a lot of individuals with Angelman love to rip that key guard off. So I would say a fixed key guard or a touch guide when possible is going to be a better way to start than maybe going straight for that hinged key guard or otherwise, or the magnetic ones. Those seem to pop off really easily too.
Mm-hmm.
And then I really focus on the family. I really focus on the education and training to make the family feel or support the family in feeling empowered in using the device, because I feel like many of our individuals, they need to hear the language, see the language to use the language, right? We know this. We know
Right.
modeling is powerful. And absolutely in this population, they want to see and do everything just like us too. So we need to provide that access, and likely for some time, and not feel like it's failed because the individual isn't using it day two.
Yeah, right. So that to me, it seems like an amazing similarity between what you're doing and what happens in the schools, right? Because, yeah, I've been trying this for 2 weeks. Can we try a different device? Because it's not working. Like, wait, it's going to take longer than that, right? And
Right.
sometimes it takes so long, it's hard to be patient. In fact, I know of a situation right now that I'm helping people with, and it's the administrators are like, well, he's had it for like a year, and I don't know, he hasn't started using it yet. And it's like, yeah, it's rarely the wrong device if it's robust and and it's got a keyboard and we've been practicing. It's really the implementation around the device that is usually, let's focus there. Like, what else can we do to implement it with fidelity?
Totally. Well, and I have reached out to the creators of this, and I'd love to plug this new thing that I learned at ATIA. Did you go to the presentation about the stepping into AAC?
Well, Caroline, I did not go because I had a presentation at the exact same time. But
Okay.
Fun fact, Michaela, who we've been talking about here.
Yes.
So that's Michaela. That is the Michaela from.
I'm putting all the pieces together. This is amazing. So I've reached out to Michaela and we've been chatting. I am so excited for this stepping into AAC. It's a collaborative project with the Angelman Syndrome Foundation and Practical AAC. And I think that this is going to be such a great tool for so many families. Of course, Angelman families are the highlight of the information, but I think all of these strategies are going to help all families in supporting their child. And I like that it's 20 weeks. I think I'm intimidated that it's 20 weeks, but also I think that gives us a really great framework of this isn't going to be today or tomorrow. We have to think about taking our time with this.
Yeah, it's you step by step, right? As the name implies. Yeah, and I love what you said there too, that it's really all families because the strategies are somewhat universal, right? Yeah, that I know they released like half of it, and I don't know when the next half is coming out. Like the first 10 came out.
Right.
But foreshadowing, we've reached out to them and trying to coordinate a time so that they can talk about, here on the podcast and share all about it. So,
Oh, fantastic.
can't wait for it to for the entirety to come out. Yeah, awesome.
Yeah.
All right, so let's go back to your the clinic and hospital. You said there's like 11 different people that maybe a family will interact with, like this interdisciplinary team. And then you said something about how you get together and talk about a situation. Is that right? Or did I misrepresent that? And the reason I say that is because I've seen enough movies about hospitals. So it's like, right, like House goes off and he talks to his team of people and they all brainstorm together, right? Like that sort of thing. Is it like that, or what? Bust that myth for me.
Yeah, I mean, I can't say that I've seen the show you're referring to, but I agree with your description and that it is us coming down. We will meet with the families, we'll prepare ahead of time. And then after meeting the families, we'll all sit down together as a large team and discuss what are our recommendations, what are our plans, and even with some families, depending on the medical complexity of the case, we'll say we need to start here and really get this under control or make sure that this medical need is met. And then these would be the follow-up steps. Because we want to recognize that a child and family needs to have their medical care needs stabilized, right?
Mm-hmm.
Before we can really implement a ton of therapies and things like that. It's also really wonderful. We have a dietitian and the occupational therapist that I work with. We are often all collaborating, especially when it comes to feeding, which can be an area that is either challenging or may require special diets, and how we're being really thoughtful and making sure that the language is there and the supports for independent feeding are there and that the nutritionist is also involved. So I think it's really collaborative. We make some wonderful, fun recommendations. I probably work most closely with the occupational therapist. Lauren DeVolk and I have done presentations together, and we really collaborate on how can we best support the individuals, both in meeting their language needs as well as their sensory or other needs that they may have.
Again, drawing upon my background knowledge, that sounds a lot like what happens in the schools, right? The best friend of the speech therapist is usually the occupational therapist. Co-treat together, brainstorm together, but get that whole team together to collaborate together. There's something that's still I'm missing a step, Caroline, that's to help me fill in the gaps here. So someone comes to visit the clinic. Different teams of 1 or 2 people meet with them separately, talking and learning about the student. And then that family leaves and you guys meet as a whole to make sure, what did you see? What did you see? What did you see? And then when do you follow up with the family? Is it like we have a Zoom call afterwards, or you come back in, or if you've traveled, we'll see you in a day, go enjoy some parts of Colorado while you get together and come back. What does it actually look like, timeline wise?
Right. I would say the majority of our cases we're able to provide my recommendations that I provided are in alignment with the treatment plan that the team has discussed. And so there's nothing that would need to be changed beyond what I already presented and talked about with the family. There are cases where we need to we have a wonderful medical nurse who runs our camp. I'm already switching gears. We have a wonderful medical nurse who runs the clinic and will then call up the family and say, maybe if there's a medication change or wanting to make sure that these steps are followed in this certain way, she will follow up with them to do so.
Gotcha. All right. Well, you brought up the camps. Let's talk about them. So is that related to the clinic or is that separate? Is a whole different thing?
It's a whole different thing. So I was really fortunate when it's almost like an onboarding process. You are hired at Children's on the AAC team, and then you go to camp. So within my first 3 months of working at Children's, I'm sleeping above one of my colleagues in a bunk bed. And so I've been participating at camp since July 2016, and then I've been running camps. We have 2 camps that we do since August of 2017. It's been a while. We had a couple years off because of COVID.
Let me pause on camps just for a second. There's another question I want to ask you that sort of popped up in my head with the clinical setting, and then we'll come back to camps.
Yeah, let's go back.
Okay. So just let me rewind for 1 second and ask you, are you the only AAC speech therapist, or do you get to collaborate? And why? Here's why. Again, drawing upon my background knowledge, lots of times in a school, you're the speech therapist. And yes, you're collaborating with those other professionals who have different backgrounds, but it can feel kind of lonely sometimes, like, who do I get to collaborate with? And yes, there might be people in neighboring schools, but how often do I get to see them or talk to them? And so my extended professional network is Instagram, So what's it like for you? Do you have other people right there that you can brainstorm? Like the person that was in your, that eventually became your bunkmate, is that someone that you work with all the time and you can collaborate and bounce ideas, or is it also somewhat lonely?
So to summarize your question, in the clinic, do I have people I can collaborate with that are AAC focused?
Exactly. Maybe other speech therapists.
Wonderful. Well, first I have to say, I feel incredibly fortunate to work with the providers that I do in the Chromosome 15 clinic. They all get AAC. I have the physicians who are so ready to support. Hey, is this individual ready for a device? Can I help you with the paperwork and getting the device funded? What do we need to do? I have the occupational therapist that I work with, Lauren. She is not only a passionate sensory integration therapist, but she has incredible passion for this population and AAC. And so she is doing AAC access evals. And then in addition to that, the clinic runs 3 times a month. So 1st, 3rd, and 5th Mondays. And I can't always be there, so I need to make sure that I have someone else that I can call on. And Alyssa Kearney is my go-to person to collaborate and brainstorm, and we have so much fun chatting about our families and ways to support them. But I really love what you've touched on, because I do recognize there's an incredible need, particularly with these really rare syndromes. And so I'm in the process of working with the Angelman Syndrome Foundation and the Dup15q Alliance, who have a ladder learning network that they've established. And the goals of the organization is to connect patients to care, connect providers to other providers, work on clinical trials, and they've established a database to collect information so that we're really making intentional and purpose when it comes to the research, that we are really seeing the gains in these different drug trials that they're starting. So in conjunction with Katie Gabrini, who is the director of the Ladder Learning Network, just in the last 2 months, we are creating a network for speech therapists who work with these populations. And we already have 20 plus, I think, speech therapists from around the world who are interested in these populations and have that collaborative network. Because like you mentioned, I could be very much on my own, but I'm too much of a people person to let that happen.
Right. Well, and you can also kind of get lost in your own world, right? So it's really meaning I could start, I need sometimes someone to challenge me, right? And to make sure that I really am right about how I'm thinking about this, or, this is the least restrictive approach, right? So having those people a team to bounce your ideas off of. And when I say a team, I mean other professionals that are doing exactly what you're doing, or close enough, like not another discipline, if that makes sense. It's a different collaboration. But let me just ask about that resource for a second. Can people, like, if they're listening to it right now and going, well, wait, I do that and I don't know what this thing is there like a way to join, or is there, is there initiation? Like, how do you get in?
Initiation sounds pretty intense. So it is I mean, it's very kind of loose at this point in some regards, that we're having our first meeting in April. So I don't know if this will get to go live before then, but there are families there are speech therapists who would be able to sign up through our listserv. So I can give you the listserv to sign up for, and you can post it on the show notes. And that's really the first part. Then once you join, you are added to our team's channel, right? And from there, we'll have documents or a place for you to post a question. Of course, because this is a rare condition, we always encourage individuals to ask broad questions, but it's really just in its infancy. It's really an email listserv at the moment, and then a place to get answers to questions or to get resources.
It sounds awesome. That's how things start, right? This is the start of a larger thing. Awesome. Okay, yeah. If you send us that link, we'll give it to Luke, and I'm sure Luke will put it in the show notes so that other people can join the listserv. Cool.
Thank you.
Yeah, awesome. Okay, so now back to camps. So you've participated in a handful. There was a hiccup for COVID. You're coming back to it this summer, right? You're going to be doing another one this summer?
So we returned to camps in 2022, and so we'll be our third year post-COVID in 2024.
Awesome. So what are some memorable experiences? Tell us some stories.
Absolutely. Well, I have to say, I have two camps that I run. One is Talking with Technology Camp, which is near and dear to my heart because it shares your name, right?
Yeah, it's a good name.
Great name. And then we have First Steps Camp. So I think my memories that are so that stick out, I think it's just to give a broad picture, we get to have 25 to 30 individuals ages 6 to 21 who come to camp, and they come from all over. And oftentimes this can be the first time that an individual has seen or met other peers or mentors that use a device. So I think for me, some of my most memorable moments is seeing that moment of we're the same.
Yeah.
This is so huge to see someone that's a friend that talks similar to the way I do, or to see a mentor who has such a rich and full life and they talk just like I do. Like, this is not a limiting factor because I use a device or tool to communicate.
Awesome.
I love those moments.
Yeah, I can totally picture that. What does the camp is like a week long?
Mm-hmm.
And so just tell us, describe how the camp kind of functions. How you find out from the beginning of the week to the end of the week.
Absolutely. So camp is typically a Sunday through Friday. We have a fortunate relationship and partnership with Easter Seals Colorado. So, and a little back history. I have to say, Talking with Technology was established in 1986 by Dr. Tracy Kovac. So we've been doing this a while. And camp is typically a Sunday through Friday program of 25 to 30 campers who stay in cabins with counselors. The counselors are provided by Easter Seals and are trained in dignity care and in being fun and vibrant people. The camp is about 200 acres of just beautiful mountain and trees and hiking trails that are fully accessible, which is just so amazing. And we have all the kinds of activities that you would hope for: swimming and zip line and fishing. And it's all adapted. So it's all thinking about how can we say, yes, we can do this. And then I come in with my Talking with Technology programming, and I bring up five of my colleagues who will be like cluster leaders. And so we have 5 groups of campers, and they're trainers, and trainers really support the communication. So oftentimes our campers are paired in a 2-to-1 adult experience. And campers in like a day, normal day. So a Monday through Thursday kind of routine is breakfast. We go outside to the flag raising. We sing a song, very much like Yay Camp. And then we go into activities. And so because we have 5 groups, that can be a lot of kids at one, or a lot of campers at one location. So we'll break the groups up, and we'll have half the groups go to Talking with Technology camp activities, while the other half is doing the rock wall and zip line. And while our Talking with Technology camp activities are really focused on 3 different areas. So social interactions, literacy, and motor. So some of our activities are, we'll have a and we'll put a bunch of letters in it. And then it's up to the trainer who's supporting the communication to really individualize that letter activity. So if they pull out the letter L, maybe that's, ooh, what words begin with the letter L, right? Or how can we flip that around? Can you find the letter L based on the individual's language level or literacy level? Then we have motor activities, which are going to be like your relay races, obstacle courses, scavenger hunts. One of my favorite things is when my colleague Jamie Chaddick puts on a Gruffalo costume and jumps out from behind trees and in the forest. And then we have our social activities. So telling scary stories or jokes around a campfire kind of engagement activities. And so that would be like the morning. And then we'll have some rest time after lunch, followed by then opposite groups going to the TWT activities or the camp activities, followed by dinner. And then every night we have skits or performances, different kinds of campfire-like activities.
Oh, sounds awesome. I mean, I want to go. It sounds like a great. Yeah, I believe me. If I could get to Colorado, I would. Let me just ask another follow-up question about that. You had mentioned like the training some of the counselors receive. What does that look like around AAC? Again, it's not necessarily like intuitive. You need to practice or learn to get good at modeling. For instance, right? So, what does that look like? How do they get to know what to do with AAC?
Absolutely. So, and I should define who is a trainer. At camp, at Talking with Technology camp, we really strive to be an independent camp, or we are an independent camp, meaning that no parents or caregivers are invited to come. So trainers can be known people, which would include teachers, special education teachers, paraprofessionals, speech therapists, as well as unknown individuals. So I have speech therapists from around the country who want to come and get this training and support. I work very closely with the graduate programs here in Colorado and encourage other graduate students to consider coming to camp to get the experience of working with individuals. And so the training that we provide really needs to meet a variety of educational backgrounds. And so historically, what we've always done is you arrive Saturday, the day before at camp, and we have training after training after training. We're going till 10 o'clock at night, every night doing trainings. And I took a step back last year and I said, this is not a great way to learn.
Yeah, it sounds intense.
Yeah, the capacity for learning is there, but also a lot for these individuals that I really want trainers to take so much away from camp. So what I've done this year, and it's our pilot program, is we've moved all of the trainings, or the majority of the trainings, to online. So we're going to do a lecture-like series that's available for continuing education units, and then really focus on our time at camp as being the labs of where we do the hands-on practicing modeling, practicing the things that really make a successful communication partner, but they'll already have that foundational knowledge ahead of time. And it's like 12 plus hours.
That sounds awesome. And if you need supplemental resources, I know of this program that's going to be 20 steps, and it's called Stepping into AAC, that also will have those. So there's no shortage
Exactly.
of resources.
Absolutely. No. And I do always try and highlight the other programs that are available because, and I think that that's a great, I'm a little nervous about this piloted program in the sense that I've been attending camp since 2016. And so I've seen these presentations year after year after year. And what I find so impactful is that each time I learn something, even if it's the same information, we got a slight spin on it. We have a slightly different example to really mull over in our heads, right? So even though I've learned a lot about modeling, I know I still have some more I can learn and ways that I can improve.
Always, right? Yeah, that's such a excellent point to make. It also sounds like such a great experience by the end of the week, how much how much you've learned, and then you bring it back and expand that to kids that aren't at camp, right? Wherever you work throughout the other 51 weeks of the year, right? Like so yeah, it just sounds awesome. What a great learning experience, how fun it is. It just sounds sometimes I wonder why can't school just be like that? Like that's
Right.
just that, like that should be the thing, that for the 51 weeks of the year.
Absolutely. Well, and that's where we have these TWT activities that we've planned and put together. But there's each group, each cluster, each day is responsible for a different day. So for instance, Tuesday is the Gruffalo and camping and all the things related to that. And it's up to, for instance, cluster 1 to set up all those activities, to talk about what language and prepare the other trainers the night before how to do that. And what we really hope is that we're instilling a way for teachers, paraprofessionals, speech therapists to really think about how we can work together as a team and set things up and really think about, are the sensory tables accessible for that person in the wheelchair? How do we need to adapt the environment to make this accessible? And then really take that home to their school environments, take that home to their private practices, and know that it's still possible to do that. We have to have a little bit of that planning ahead of time.
Yeah, for sure. Wait, are there any other challenges that you can think of that sort of, barriers that get in the way? Or is it, or maybe that if you were thinking about starting an AAC camp, the challenges that you faced at the beginning?
Mm-hmm. Yeah, I think it's really interesting. I think sometimes a challenge, and I want to say this thoughtfully, can be the adults. And that we need to remember to have fun. Yeah. And even though we're at camp and all the fun is around us, we can get bogged down by thinking we have to model this communication or the child has to say this. And no, we just need to have fun and everything will come from that.
Yeah.
So
the rest will take care of itself. It's so funny. Rachel and I kind of talk about that all the time. And it's like, it's sometimes you have to learn how to have fun.
Right.
I think it's intuitive, but it's really not for a lot of people. And so, it's okay to laugh. It's okay to, spill the paint. It's okay to pretend to be scared when the Gruffalo jumps out. No one's going to laugh at you. They're gonna enjoy it with you.
Absolutely. My colleague and I talk about this, and we strive to have a good belly laugh from both the kid and from us.
Yeah.
Because that's going to be indication of we're having an incredible, meaningful moment, and everything else will go fine from there.
Yeah. I could not agree more. That's what makes life so much fun to live, right? Are those sorts of moments, right? That's awesome, right? I mean, is there anything else you find super rewarding from the camp?
I mean, I think I always try and pause the last night of camp. We have a dance and we raid the costume closet and everyone gets dressed up in these 1980s prom gowns and ridiculous ties. And we just have such a fun night. And I always try and pause at some point and look around at all of the joy that comes together when we connect and have fun.
It sounds rad.
Yeah, it really is. Well, and I would, to go back to your previous question about like how do you start a camp? I mean,
Yeah.
I don't know that I'm the best expert in that just because I have inherited this amazing program. But I would say that there are absolutely a few things to consider. And I would love to create another community where we're supporting other states and community and cities to have their own camp. So I think the first thing would be to go to a camp or go to a few camps, if possible, to see what these different camps are like. I know I want to go to other camps because I think that I have a lot to learn from others. And from there, you can have an idea of, do I want to do a day or overnight program? What does the care look like for 3 hours with, individuals that do have care needs, right? Or could we be able to provide an overnight camp, which would require 24 hours of care? Working with local organizations. So we've partnered with Easter Seals to make sure that we're providing that care. What other organizations are available in the home communities that you're working with? I think, and I didn't get a chance to mention it just yet, but whether you want to do a family camp or an independent camp. And so our First Steps camp is a family camp where the whole family, parents, siblings, all come up to camp and get the experience of being outdoors, having an inclusive environment where we're not any different. We are all here together and we're all sitting down at a table to eat a meal together and we're laughing and having a great time. And then also using that time when the parents have someone to watch the campers or the children to then participate in a really great learning environment. And then thinking about how can we get like that experience firsthand for individuals who are available or interested to run a camp? I would say reach out to me. I'm happy to help. And also I've been working with Tina Moreno and Gina Cunningham, who run Camp Alec, and we would love to be building this community of individuals who are wanting to get kids outdoors to meet their needs.
Awesome. Last question. I always like to ask, what people are curious about, what they're questing after, what sort of got them, tingling professionally about like, I want to learn more about this, or I'm excited about this. What's on your mind there? What are you questing after?
Oh my goodness. Well, so much. But what's next for me to learn? I would say I really want to dig into artificial intelligence. I think that there is so much happening in that space. At ATIA, there's a lot of really great starts, and I'm really excited to see some of these tools that are going to continue to come out and support more communication.
Yeah, me too. What's happening with generative AI, and it's happening so quickly, does seem like a game changer, and it's and we don't even really know all the different places it can go yet, right? So I agree. It's got me really excited to learn more and to be thinking about different ways that that can support people's use of language and support their communication.
Right.
All right, Caroline, any final thoughts?
No, thank you so much for having me. I hope that anytime that a clinician hears that their student or patient is working in a multidisciplinary clinic with another professional, that they'll be willing to chat and collaborate with that person on the other line, and then consider coming to camp. It's so much fun.
Awesome. All right. Thanks, Caroline.